and I'm working as Associate Professor of Surgery in Surgical Unit 5. Today we'll discuss some diseases of the esophagus. The actual topic is management of the Achlasia and Carcinoma of the esophagus. Before coming to the topic, I would like to discuss some anatomy of the esophagus, and after that we'll start the actual topic. So, as you remember in the first prof, the esophagus is the digestive tract starts with it, and it's a narrow muscular tube extending from pharynx to the stomach, and it begins with the lower part of the neck from at the level of C6 and extending up to the thoracic 11 vertebrae into the cardiac orifice of stomach. And it gives the passage of chewed food and liquids during the third stage of deglutition. There are three parts of the esophagus. It's cervical part, which is lying in the neck, and its length is about 4 centimeters, and it extends from lower border of cricoid cartilage to the superior border of the medium sterni. Then comes the thoracic part, which is 20 centimeters in length and is starting from superior border of the medium sterni to the esophageal opening in the diaphragm. And the third part is the abdominal part, and it's got its length is about 1 to 2 centimeters, and it extends to create esophageal opening in the diaphragm to the cardiac end of the stomach. And there are two sphincters. Sphincters are the gates of the esophagus. The first one is the upper sphincter, and the second one is the lower sphincter. The upper sphincter, it prevents the entry of air, and the lower one prevents the reflux of the gastric contents into the esophagus. The upper one is an anatomical sphincter, and it's made of striated muscles, and it lies at the junction of pharynx and esophagus, and it's produced by the cricopharyngeus muscle, and normally it is constricted to prevent the entrance of air into the esophagus. The lower one, it's a physiological sphincter, and it's located in gastroesophageal junction, which is the junction between the stomach and esophagus, and it prevents the gastric reflux. Usually acid contents are lying in the stomach, and it prevents its reflux into the esophagus. Otherwise, if it becomes impatent, if it's not patent, then there might be some reflux into the esophagus, and it may cause esophagitis, which we call reflux esophagitis. So there are two, these are the picture of the two sphincters. This is the upper one, upper esophageal sphincter, which prevents the air entry into the esophagus, and it lies in the cricopharyngeus muscle. And this is the lower one, which is lying at the junction of esophagus and stomach, and it prevents the gastric contents to come back to the esophagus. Now let's move toward the histology. The esophagus has got 4 layers, as the other GI organs are having. That's mucosa, submucosa, muscularis, and serosa or adventitia. But the mucosa of the esophagus, it has got 3 more further layers. Like, one is the epithelium, which is highly stratified squamous and non-keratinized. Then comes the laminopropria. The third is the muscularis mucosa, which has got only longitudinal layer of the smooth muscle fibers. So these all 3 layers makes the mucosa. After that comes the submucosa, and it includes mucus, esophageal glands, and then muscular layer. The muscular layer is divided into three parts. The upper 1/3 of the esophagus, the muscular layer is created by skeletal muscles, and the lower one third, it's created by smooth muscles, and the middle one third, it's a mixture of smooth muscles and skeletal muscles. So the muscular layer has got three layers, three parts. The upper one third of the esophagus is uh, uh, has got the skeletal muscles, the lower one third has got smooth muscles, and the middle one third has got the mixed skeletal and smooth muscles. Then comes the adventitia, the outer layer, which is composed of dense connective tissue that has many elastic fibers. So it has got all the four layers. In this picture, you can see in the center this mucosa, and then submucosa and muscularis mucosa, and then adventitia. Now let's come to the topic. Today's topic is achlasia. Achlasia is failure to relax the sphincter. It's one of the part of the esophageal motility disorders. There are other disorders also, like Webb and there are other varieties of the esophageal motility disorders, but today I'm concerned with the achlasia only, and it's a failure of smooth muscle fibers to relax, which can cause the lower esophageal sphincter to remain closed. So what happens, usually what happens when a food comes into the esophagus, this esophageal sphincter becomes open and the food goes into the stomach. But in this abnormality or disease, what happens, the lower esophageal sphincter does not open and it remains closed. So the food stays in the esophagus. And it is characterized by degeneration of myenteric neurons that innervate lower esophageal sphincter and esophageal body. So in this disorder, what happens? The lower esophageal sphincter does not open during the deglutition. So the food stays in the esophagus. And what are the clinical features? How the patient presents with this disease? So it's very common in 25 to 60 years, and it's equally distributed among the male and female gender. And the first symptom is what? Dysphagia. What is dysphagia? It is difficulty to swallow. In this type of the disease, what happens? The dysphagia is to the solids and liquids both, and it is the most common presenting symptom. And in 90% of the patients, it's present. But in this disease, the dysphagia we call it's intermittent dysphagia. Intermittent means some after some period, days or period, the esophagus becomes open, and the food may go into the stomach because of the gradient of the flow of the food which is occupied in the esophagus. So in this achlasia, what happens? The dysphagia is intermittent. So sometimes in the day or after a few days, some food may pass, but because of the this food gradient. Otherwise, the dysphagia is both for the solids and liquids. The other symptom which is experienced in this disease is regurgitation. The regurgitation is, there's a difference between regurgitation and dysphagia. Dysphagia is difficulty in swallowing, and regurgitation is some fluid comes back in the mouth usually during sleeping. So the regurgitation is the second most common symptom occurring in 60% of the patients. The first one is the dysphagia, which is usually intermittent, and it is for solid and liquids both, and then the regurgitation. And nocturnal regurgitation is mainly experienced. That is during sleep, what happens, the esophageal contents comes back into the mouth, and it may lead to nighttime cough and aspiration. The patient may aspirate it because the contents are coming in the mouth, and through the larynx it may go into the respiratory tract, and it may cause cough and aspiration. And in the late stage, patient may experience weight loss. And some people may feel chest pain and heartburn in 30%. And these are because of these two symptoms, are because of the direct irritation of the esophageal lining by retained food, pills, or acidic byproducts of the bacterial metabolism of the retained food. Because most of the time, the food stays retained in the esophagus. So it may produce some irritation, and which may lead to chest pain and heartburn. These are the common symptoms of the achalasia. And how do we diagnose it? The diagnostic, there are different tools to diagnose it. Like we can do a barium study, and barium study for it, we'll call it barium swallow. Because if you want to visualize like esophagus, then we call this study barium swallow. A little amount of the barium is given to the patient. And if you want to do to see stomach, then we do barium meal. So the barium meal visualizes the stomach, the whole stomach, and a little barium goes to the duodenum. And if you want to see the whole small bowel, then NG tube is passed, and then through it barium is given, and this barium goes into the small bowel, and we call that barium follow through. So in this condition, like for achalasia, we want to diagnose the pathology in the esophagus. So we do barium swallow. And so can you differentiate between the barium swallow, barium meal, and barium follow through? And if we want to see the colon, then we give barium enema. There are 4 varieties of it: barium swallow, barium meal, barium follow through, and barium enema. So this barium, when we do this barium study, then the esophagus will be looking like very dilated, and air fluid level will be seen. And the classical finding in barium swallow for the achalasia will be the bird's beak. Dilated esophagus will end with taper at the end of the esophagus. The other modality is upper GI endoscopy. Is the next diagnostic test. So this is the picture which you can see in the barium swallow. You can see the dilated esophagus, and then it's tapering into this bird's beak, like a bird's beak. So this is the picture of the barium swallow of achalasia. And when we do endoscopy of this patient, you can see on this right side the bird's beak appearance of the barium swallow, the dilated esophagus, and then it's ending tapering over here. And in endoscopy, when we do endoscopy, the dilated esophagus will be seen, and it will be seen narrowing in the lower part. But the gold standard to diagnose achalasia is esophageal manometry. It has got the highest sensitivity for the diagnosis of the achalasia. So if you are asked in the exam, what is the gold standard, or what is the best diagnostic test to diagnose achalasia, so you have to answer this esophageal manometry rather than barium swallow or upper GI. These two tests help in diagnosis, but the sensitivity, highest sensitivity is, so this is the gold standard. Esophageal manometry is the gold standard to diagnose achalasia. During this manometry, what results are coming? There will be a peristalsis of the distal esophageal body. I think you can easily understand what does this terminology mean, like a peristalsis. Peristalsis means there's the normal movement of the GI tract, and in this normal movement is lost, then it will be called a peristalsis. And then there's incomplete or absent lower esophageal relaxation. So the lower esophageal relaxation will be relaxation will be absent or will be incomplete, and increased pressure will be there. Normal pressure is 10 to 45 millimeter of mercury, and in esophagia, in this achalasia, the pressure is increased. So these three findings are seen during manometry. So a peristalsis of the distal esophageal body, incomplete or absent relaxation of the lower esophageal sphincter, and increased pressure of the lower esophageal sphincter. So now let's come to the treatment or management. The primary goal is to reduce the basal pressure of lower esophageal sphincter. So the treatment options are medical therapy, botulinum toxin injection, pneumatic dilatation, and surgical myotomy. These are the different modes of treatment. And symptom relief, particular relief of the dysphagia, is accepted as the primary desired outcome. The outcome of all these remedies should be relief of the dysphagia. So let's discuss all these treatments individually. Medical therapy first. It's inconvenient, and the medical treatment is inconvenient and modestly effective, and it's got side effects as well. It's reserved for those patients who cannot tolerate invasive treatment. So it's not very much effective. And pharmacological therapies attempt to decrease the LES pressure, lower esophageal sphincter pressure, by causing smooth muscle relaxation. So these medical remedies causes relaxation of the smooth muscles, so decreasing the lower esophageal sphincter pressure. The nitrates were first recognized as effective treatment, but it has got some lot of side effects like systemic vasodilatory effects, headaches, and it limits the tolerability of the patients. So the nitrates are the first drug which can be used. Here there is the calcium channel antagonists. They have a better side effect profile when compared with the nitrates. 30% of the patients report adverse side effects like peripheral edema, hypotension, and headache. So these two drugs can be used, nitrates and calcium channel antagonists. Then toxin, botulinum toxin, can be injected into the lower esophageal sphincter with the help of endoscopy, and it targets the excitatory acetylcholine releasing neurons that generate LEC basal muscle tone. So it targets the excitatory acetylcholine neurons. It is apparent that with repeated injections, the response rates reported are similar or lower. So with immediate repetition of the injections are required, and with the repetition, the response becomes lower. Then pneumatic dilation. Pneumatic dilation means pneumatic dilation remains one of the most effective first-line therapies for the. So these are the first-line therapies for achalasia. Rather than medical therapy, it should be preferred as the first-line therapy for achalasia. And balloons of 30 to 40 millimeter can be inflated, and it's curative in 75 to 85% patients. So it's the goal. It may say this is the first-line therapy, and if it doesn't the patient doesn't respond to this pneumatic dilatation, then the surgical the treatment should move towards the surgical therapy. These are the complications of the pneumatic dilatation, like gastroesophageal reflux and esophageal perforation may be possible. So how it is being done? You can see here during with the help of endoscopy, guide wire is passed through the closed or incompletely closed lower esophageal sphincter, and over it this balloon is passed. When the balloon crosses the LES, lower esophageal sphincter, then this balloon is filled with with air. You can see over here the balloon is filled. So it may cause the dilatation of this narrow tract, and it may relieve, this achalasia may be relieved. So over here it's very tight when it passes through it, and then balloon is filled, and then multiple dilatations are required to relieve the symptoms. So you can, I hope you can understand through these pics that how this dilatation is done. Then comes the surgical therapy. If the patient does not respond to the pneumatic dilatation, then we move towards the surgical therapy. And the success rates are more than 90%. The operation which is done to relieve achalasia, it's called Haller's myotomy. Myotomy means the muscles are cut and only the mucosa is kept patent. The other three layers, like as we have discussed already, that histologically esophagus has got 4 layers. From outside in, you have got serosa, muscularis, and then some mucosa, and then mucosa comes. So we have to make a cut from outside to the serosa, then muscles, and then some mucosa. And then what happens, the mucosa pops up. So this is the myotomy. Actually, the strength comes in the muscular layer. So this is why it's called myotomy. The serosa is very thin and some mucosa is also very thin. So the primary aim is to cut the muscle layer. Cutting of the muscle of the lower esophagus and cardia. So it may be done by open method like the laparotomy, upper midline laparotomy. This is called open Haller's myotomy. It can be done with the laparoscope, with the help of the laparoscope, and call it laparoscopic Haller's myotomy. And it may be done with the robotic Haller's myotomy. So what happens over here? See this is the muscular tube, and a cut is given over the serosa, and then all the muscles are cut. 3 centimeter. This cut is around 5 centimeter, 3 centimeter over the esophagus, and 2 centimeter in the cardia, crossing the junction, and over the upper stomach. 2 centimeter here in the stomach and after the junction, and 3 centimeter above the junction. So this is the area, the cardio-esophageal junction, and this is how it is cut, and this is how the mucosa pops up. You can see now the muscles have been cut. Now mucosa is popping. So this is the principle. This is the principle of this surgery, which is called Haller's myotomy. And as the sphincter is cut, so what will happen? It may lead to reflux of the stomach contents into the esophagus, because now the valve is not patent. It cannot be closed, so the passage will stay patent. So to stop this reflux of the gastric contents into the esophagus, we do an additional procedure. This is called anti-reflux surgery, and this is the anterior wrapping of the fundus around this cut or myotomy. This we called anti-reflux surgery. So 2 procedures are being done. One is the Haller's myotomy, and to prevent reflux of the gastric juices into the esophagus, we do some anti-reflux surgery, and we have to wrap this fundus of the stomach around this myotomy incision, and this we called anterior anti-reflux surgery, or DORS. This is DORS method. There are other anti-reflux surgeries also, like Nissen fundoplication, but in this we do DORS or anterior anti-reflux surgery. Then, so this achalasia topic is complete now. Now we'll move towards the carcinoma of esophagus. Carcinoma, carcinoma of the esophagus. It's the tumors of the esophagus are more malignant than benign, and unfortunately, the esophageal cancer often discovered 5-year survival is very bad for the esophageal carcinoma. It's less than 10%. And even for the potentially resectable cancers, 5-year survival is not more than 30%. It's the 7th leading cause of the cancer death worldwide, and 30 to 800 cases per 1 lakh persons in the and usually it's more common in the northern Iran, Russia, and northern China. Squamous cell carcinoma is more common than adenocarcinoma. It can be divided into squamous cell carcinoma and adenocarcinoma. And more than around 95% of the cancers are squamous cell carcinomas. But over the last 2 decades, the incidence of the adenocarcinoma is increasing. And adenocarcinoma is seen in the distal esophagus and the gastroesophageal junction. So it is increased now. The incidence of the adenocarcinoma is now increased. And currently it accounts about the 50%. In age and sex, esophageal cancers are most commonly seen in the 6 and 7 decades of the life. And it's more common in the males than the females, with the ratio of 7:1. Etiology, these are the different possible causes of the esophageal carcinoma. These are the causes of the squamous cell carcinoma: the vitamin deficiencies, chronic ingestion of the hot liquids or foods, poor oral hygiene, exposure to nitrosamine in the environment of our food. In Western culture, cigarette smoking and chronic alcohol exposure may lead to the cause of the esophageal carcinoma. Certain medical conditions like gastric injury to the esophagus, it may lead to esophageal carcinoma, or HPV infection can lead to esophageal carcinoma. And for adenocarcinoma, Barrett esophagus is common. What is Barrett's esophagus? It's metaplasia of the epithelium of the lower part of esophagus, which is usually stratified squamous epithelium, but it becomes reformed to the adenocarcinoma, columnar intestinal epithelium. That leads to, so the lower part of the esophagus becomes metaplasia is going on in the epithelium, and the squamous epithelium is converted to the columnar epithelium. Symptoms again is the dysphagia is the common presenting symptom, which is also seen in the Achlasia. But dysphagia in this carcinoma is really progressive dysphagia. Progressive means that initially the patient can take liquids easily, but there's difficulty in taking solids. But gradually, as the lumen becomes blocked and the tumor becomes increased in size, then after that, the dysphagia progresses and liquids are also not taken. And in the end, if the disease keep on progressing, the patient is not able to even swallow saliva. So initially it is experienced for the solids, but eventually it progresses to liquids. And then because of the decreased intake, the weight loss is marked. Weight loss can be seen in the carcinoma esophagus patients. And in the last, the pain may be seen, may be experienced, like epigastric retrosternal over the bony structures. Pain may be experienced, but it's in very late stage. Usually it progresses, it presents with the dysphagia and weight loss. And hoarseness can be seen because of the involvement of the recurrent laryngeal nerves, which are lying very close to the esophagus. And if they are involved because of the disease, then hoarseness can be experienced, and respiratory symptoms may be seen because of the involvement of the trachea, or there might be some fistula or communication between the esophagus and trachea, and it may lead to respiratory symptoms. Signs examination findings are usually normal. Some lymphadenopathy can be seen in the laterocervical or supraclavicular areas if the disease is advanced. What is the differential diagnosis? Maybe benign neoplasms or Achlasia or hiatal hernia can be kept for the differential diagnosis of C. esophagus. This is the TNM classification of the esophageal carcinoma. This TNM classification can be applied to the other carcinomas also, like stomach or colon. It's almost the same configuration is seen. Like TX means no tumor is assessed, T0 means no evidence of the primary tumor, TIS is the carcinoma in situ, present only at the origin. Then this is the difference. This three like TX, T0 and TIS is same for other tumors also. But when we come to the T1, then the carcinoma invading the lamina propria or submucosa. So the carcinoma is present in the mucosa, all the three layers of the mucosa, and if it may reach or cross the submucosa. Then if it stays up to submucosa, then we call it T1 stage. And T2 means that when the muscularis propria is involved, and T3 when the adventitia is involved. So as you remember, the four layers of the esophagus, first is the mucosa, then submucosa. So if it lies between up to the submucosa, then we call it T1. But when it involves the muscularis propria, then we call it T2, and T3 when the carcinoma involves the serosa or adventitia, the outer layer. And T4 means when the other it is locally spread to the other tissues like trachea or other neighboring structures, then we call it T4. And same way, if node is not involved, then we call it N0, and if the nodes are involved, then N1, and metastasis M. So TNM actually has got T stage, N and M. N is in the nodal involvement. If nodal involvements are there, then N1, and nodal not there, then N0. And M is also the metastasis, distant metastasis is there. Like if the cancer moves towards the lungs or liver, or some other distant, like blood-borne metastasis, then we call it M1. And if there's no distant metastasis, then we call it M0. So it's very easy to remember N and M. N0 means no node involved, N1 means nodes are involved, and M0 means no distant metastasis, and M1 is distant metastases are there, either liver or lung or the distant organs are there. Actually, you have to remember T1, 2, 3, and 4. So according to that, we can divide it into stages. So stage 0 is when the T is in situ. Only the tumor cells are present in the mucous membrane origin, and no nodes are involved and no distant metastasis. Then the 5-year survival rate will be 75%. If the stage is 0. If the stage is 1, it means that the T stage is 1. T stage 1 means that the disease is lying in the mucosa and maybe up to the submucosa. And there's no node involvement, there's no metastasis. So the survival rate may be more than 50%. If the stage 2, again divided into T2A and 2B. 2A means if the T2 is there. T2 means that muscularis propria is involved. Like first layer, mucosa, submucosa, second layer is involved, and third layer is also involved. And there's no nodal involvement. Then we call it T2, stage 2A. Or if even the serosa is involved, like T3, but there's no nodal involvement and no distant metastasis, then we call it 2A. And then the survival rate is 40%, 5-year survival rate. And if it's 2B, then we call the N1 is involved. So nodes are involved, then either it is T1 or T2. If the nodes are involved, then we call it 2B. And survival rate becomes again decreased to 20%. And T3 stage is there. T3, stage 3. In stage 3, the T is 3, like adventitia is involved. And node is also involved. Or the local metastasis is there, the surrounding tissues like trachea and other lymph nodes are involved. Trachea is involved, or maybe vessels involved, and no node. Even then, it is a stage 3. And the survival becomes decreased to 15%. And stage 4 means that any T, any N, like T may be 1, 2, 3, 4, and N1 may be there, but distant metastasis is there, then we call it a stage 4. So the stage 4 is labeled to have a disease which is distant, like in the blood-borne metastasis is there, and the liver or brain or the lungs are involved. And then if the patient has got stage 4 disease, then less than 1% survival rate, 5-year survival rate. So it may be divided into stage 1, stage 2A, 2B, 3, and 4. So stage 1 is involving the 2 layers, that is mucosa and submucosa, and no nodal and metastasis. Stage 2A and 2A means the second layer, third layer, muscularis mucosa, muscularis propria is involved, and no nodal involvement and no metastasis. Stage 2B, nodal involvement is there. Stage 3, nodal involvement is there, and the T stage is 3 or 4. And in stage 4, there's a distant metastasis. So the disease goes beyond the organ and it moves to the other organs of the body. How it is diagnosed? Initially, barium swallow can be done. It's very sensitive, and it may detect the strictures and intraliminal masses. And barium swallow, you already know that we have discussed it in Achlasia, that a barium drug is given, and then X-rays are taken, and the pictures come in the X-ray. So this is the picture of the barium swallow of the carcinoma esophagus. In the upper part, you can see this is dilated, and there is stricturing over here. This is shouldering. We call it shouldering. This sign is called shouldering. From here, as we have a shoulder, from here the cut down is there, and then the stricture narrowing. You can see narrowing here in the lower part. The upper part is dilated, and there is a shouldering, and lower down there is a stricture. So this is the typical picture of the carcinoma esophagus on barium swallow. Again, over here you can see this dilated part of the stomach, of the esophagus, and this shouldering here, and then a stricture, a small stricture can be seen. So this is narrowing of the, this is because the tumor lying over here, it causes pressure over the lumen, and the lumen is blocked. And the diagnostic test for this carcinoma esophagus is upper GI endoscopy, esophago gastroduodenoscopy, and it because of this endoscopy, we can visualize the tumor directly, and we can take the biopsy or tissue for diagnosis. So this is the surest way of diagnosing this carcinoma esophagus. So if you are asked one test which can diagnose this carcinoma esophagus, this is the answer should be endoscopy rather than barium swallow. So on endoscopy, this tumor can be seen over here. This is the esophagus normal, and over here the tumor, you can see this tumor. And during endoscopy, you can take a biopsy and send it for histopathology. So it will confirm and establish the diagnosis. Son. I'm sorry for interruption. There is something wrong. Okay. So after endoscopy, we can go for the endoscopic ultrasound. Endoscopic ultrasound will be helpful in staging the disease because it can find out which layer is involved. Like through the endoscopy, this ultrasound probe is inserted over in the esophagus, and it from the inside it can uh, give a picture that what layers are involved. And T staging is usually done with the endoscopic ultrasound. Whether it's T1, T2, T3, it can be can be diagnosed through the endoscopic ultrasound. And also, and staging like immediate lymph nodes can be diagnosed through this through the probe of the endoscopic ultrasound. And then CT scan should be done to stage the diagnosis to find out the distant metastasis. So abdominal and chest CT scan can be prescribed uh, to see the presence of metastasis in the lungs or liver and adjacent structures. So to stage the disease, you can use the CT scan. You can see over here, this is the tumor of the esophagus, and this is the lumen which is remaining in the esophagus. Over here also, this is the trachea, and this is stricture. So over here, this narrowing, and you can diagnose the, you can see this is the, you can see tumor here. And also it is used to stage the disease, like you can assess the liver if there is any mats, or lungs if there are any mats, and other tissues, other surrounding tissues. If the disease is involving the surrounding tissues, it can be diagnosed through its CT scan. And then bronchoscopy should be done if there is like to exclude the trachea because sometimes when the disease is progressing, it may cause the fistula in the trachea, and it can be diagnosed through the bronchoscopy. Invasion of the trachea can be diagnosed through the bronchoscopy, and bone scan can be asked to see the bone metastasis. This is also comes in the distant metastasis, stage 4 disease. And certain lab investigations are done, like for anemia, complete blood count, liver function tests. To if there is an abnormality in the liver function test, then you may diagnose that the patient is having hepatic mets. And like serum calcium can be estimated, and then PT prothrombin time and APTT should be asked for surgery to get help in surgery. Then treatment comes. There might be some medical treatment. Usually the treatment of the carcinoma esophagus is surgical, but the medical treatment can be given if patient cannot tolerate surgery, then some supportive treatment can be done. And the goal of the therapy should be palliation of dysphagia and allowing them to eat, like medical therapy. Just support can be given in helping patient to get temporary relief of dysphagia. Medical care can be done. So the chemotherapy itself can be given if the patient is not fit for surgery, or radiation therapy can be given to relieve the dysphagia. 50% may be relieved for the temporarily can be relieved, or there might be some combination of the chemotherapy and radiotherapy can be given. And this combination of the chemotherapy and radiotherapy, if it is given before surgery, to prepare the patient for surgery, we call it new adjuvant therapy. And if it is given as a treatment and patient is not fit for surgery, so the chemo and radiotherapy given as a treatment purpose, then we call it adjuvant therapy. So the new adjuvant therapy is what? Before surgery, the patient is given chemotherapy and radiotherapy to downstage the disease. Like if the disease is like to downstage the disease, like if the patient has got stage 2, then chemo and radiotherapy is given, which is called neoadjuvant therapy, then stage can be down stage. It can go to stage 1, and then surgery will give a better result. Laser therapy can be given to achieve the temporary relief of the dysphagia. And if the patient is not at all fit for even chemo radiotherapy, then a stent can be placed, which can relieve temporarily dysphagia. It will not cure the disease, but it will just relieve the dysphagia, and patient can eat and drink after this metallic stent. What are the indications of surgery? It is resectable esophageal cancers, and the second indication is high-grade dysplasia of Barrett's with patients of Barrett's esophagus. These two are the indications of surgery. So such patients are esophagus is resected. Surgical care. So esophageal resection remains the crucial part of the treatment of the esophageal cancer. There are different surgeries which are done for relief the carcinoma esophagus: Ivor-Lewis operation, transhiatal esophagectomy, McQueen 3-stage operation, left thoracoabdominal approach, thoracoscopic and laparoscopic esophagectomy, robotic esophagectomy. These are the different modalities. The main surgeries are Ivor-Lewis operation. In Ivor-Lewis operation, what do? We have to do laparotomy and make a stomach tube to replace the esophagus, and then thoracotomy was done. Right side thoracotomy is done, and esophagus mobilized, and the tumor is excised, and anastomosis of the stomach tube is done with the upper esophagus in the thorax. So it is 2-stage surgery. Like Ivor-Lewis operation is 2-stage. One is the laparotomy, opening of the abdomen and making a tube of the stomach, and the other stage is the thoracotomy and dissection of the tumor esophagus and excision of the tumor of the esophagus, and anastomosis of stomach tube is done in the thorax with the upper esophagus. Then there is a transhiatal esophagectomy, in which laparotomy is done and stomach tube is found, and dissection is done in the thorax blindly, and another incision is given in the left neck, and the stomach tube is pulled up in the excision of the tumor is done, esophagus, the whole esophagus is done, and upper esophagus is anastomosed with the stomach tube in the neck. This is called transhiatal esophagectomy. McQueen 3-stage operation, in which 3-stage means one is the laparotomy, second is the thoracotomy, the other is the left neck incision. So all 3 parts are operated, and this can be done. And if the left thoracoabdominal approach is done, then thorax and abdomen is open from the on the left side, and the stomach tumor is removed, and anastomosis is done in the thorax. And these are the recent advances that these whole operations can be done with laparoscope, the help of the laparoscope and robot. This is the Ivor-Lewis operation performed by using abdominal and thoracic incision. See over here, the upper abdominal incision is given, and this is thoracotomy and the 4th or 5th intercostal space, and this tumor is cut from here up to the junction, taking a part of the upper stomach, and then this tube is taken up in the thorax. This part of the esophagus. Yes
सर, ये टाइम खत्म हो गया और दूसरी टीचर आ गई हैं, 12 बजे उनकी क्लास है.
अच्छा, बस 2 मिनट में खत्म कर रहा हूँ.
आपकी 11:30 तक की क्लास थी ना सर?
हाँ, वो अब शुरू लेट हुई ना, अब मेरा टॉपिक इतना बड़ा है, क्या करूँ.
अच्छा,
2 मिनट दे. हाँ, ओके. Tumor is excised, and this stomach tube is anastomosed with the upper part of the esophagus here. In the transhiatal, abdomen is open and left cervical incision is given. And over here, upper abdomen is open through this midline incision, and then left over here, the left neck incision is given. The whole tumor is excised, and this stomach tube is pulled up in the neck and anastomosis in the neck. And 3-stage, all 3 abdominal incision, thoracic incision, cervical incision is done. See, abdominal incision, thoracic incision, and cervical incision. And the whole tumor is excised, and then this stomach is pulled up in the neck and anastomosis here. The contraindications are metastasis to the N2 nodes, or liver and lungs are involved, then surgery is not done if the stage 4 disease is there. And if the invasion of the adjacent structures are there, laryngeal nerve, laryngeal nerve, aorta, or trachobronchial tree, then the surgery should not be done. And if the comorbids are there, like cardiovascular disease, respiratory disease, then the surgery should not be done. So these 3 are the contraindications for surgery. Thank you so much. Cool. Okay, I'm closing the session now. If there's any question, you can ask. हाँ, वो कर लिया मैंने क्लोज. ठीक है. हाँ हाँ, एंड हो गया. ओके लव.
End कर दूं?
If you have got any question, you can email me and I'll reply. Because we have got short of time. Another teacher is waiting, so I cannot take questions now. So you can email me and I'll try to respond to you. Thank you very much.